Hello everyone, welcome back. In this video, we'll be reviewing transplant pharmacology. Some general information is prior to transplant, cross-matching to assess compatibility for human leukocyte antigen, HLA, and ABO blood groups to prevent any immune rejection. This is just making sure that the organ going into the patient matches the patient along with the blood type, which we'll be reviewing shortly. Auto rejection means requires a biopsy and a high dose of steroids. That's basically when the body itself is rejecting the organ, and basically a high dose of steroids helps calm the body down a little and prevents it from attacking itself. An allograft is a transplant of an organ or tissue from person to person. An isograft is a transplant from genetically identical twins. And an autograft is a transplant from one site to another in the same patient. For blood matching, we have type A, which reacts with type B and AB, type B, which reacts with type A and AB, type O, which only matches with O but reacts with type A, B, and AB, and lastly, type AB, which matches A, B, and AB. Complications that may occur in the transplant include immunosuppressant drugs, which can cause metabolic syndrome, high risk for CVD, so you want to control blood pressure, blood glucose, cholesterol, and weight. Cancer, a high risk of skin cancer, so sunscreen must be used. And all drugs may increase blood pressure, blood glucose, and lipids. So you want to use a daily log of patient's temperature, weight, blood pressure, and blood glucose just to be able to keep track of it. And you want to avoid any over the counter medications or herbal remedies. Complications that may come with tacrolimus or cyclosporin include nephrotoxicity, diabetes, and hypertension. So, when we are treating these patients, we first start off with the induction treatment given before or at the time of transplant to prevent any acute rejection. The most common drug is basalomaxalab, which is an IL-2 antagonist. If there is a high risk of rejection, then an anti-thymocyte globin is given for maintenance treatment. First line is tacrolimus. The first line for antiproliferate agent is mycophenolate. Other drug options include azathioprine, everolimus, sirolimus, belatacept, steroids, antithymocyte globins, and basilomaximab. So if the patient is automatically given the transplant, the organ, the body may reject it. So we have to first suppress the body from attacking itself since it is a foreign object in the body. And this is done through immunosuppression. So the goal is to decrease any toxicity risks and graft rejection. We want to monitor trough levels for pre-transplant vaccines. These include the flu vaccine, the inactivated one, the pneumococcal vaccine, varicella, and you also want to vaccinate patients in the household members so they don't carry any of these diseases as well. To reduce any infection risks, you want to wash hands on a daily basis, keep away from any contaminations. You want to keep up with vaccinations. This does not include any live vaccines and treat any infections that may occur. For induction therapy, we have the antithymocyte globulin. The mechanism of action is it attacks the T lymphocytes. ADRs include infusion reactions, leukopenia, and thrombocytopenia. Black box warnings should only be given by experienced physicians, and you definitely want to pre medicate the patient for any infusion related reactions. For bacilameximab, you want to look out for any nausea, vomiting, or diarrhea, but for the most part, this medication is much more well tolerated for patients. Moving on to maintenance therapy, we have prednisone, which is a steroid. This is used for short term, and with long term use, you want to look out for any adrenal suppression, Cushing's syndrome, poor wound healing, hypertension, diabetes, acne, osteoporosis, or any stunted growth. We have mycophenolate, we have the mofetil and the acid. So we have brand names Celcept and Myfortic. So it's important to know the difference between the two. And the mechanism of action for these include antiproliferates, which decrease hormonal contraceptions. So, with patients taking these, you want to make sure there's a backup contraceptive, and these could also decrease the levels of cyclosporin when given together. ADRs include leukopenia, diarrhea, GI upset, and vomiting. Black box warning includes infections, lymphoma, skin cancer, birth defects, and spontaneous abortions. Contraindications, these should never be taken on an empty stomach. When counseling patients on these medications, you want to make sure to counsel them to take the missed dose if less than 4 hours has passed. If more than 4 hours has passed, then skip and take on an empty stomach. You want to avoid in pregnancy and avoid taking with any antacids or multivitamins because they could mess with the absorption of the medication. Patients on this medication are usually in REMS programs. These drugs are not interchangeable. You want to protect them from light, and Celcept can only be given with D5W only. Next, we have azathioprine. ADRs include leukopenia, anemia, thrombocytopenia, hepatotoxicity, and myelosuppression. We have tacrolimus, brand name Prograf, and cyclosporin, brand names Neooral, Gengraph, and Sandimmune. These are calcineurin inhibitors. Inducers can decrease the concentration, and inhibitors can increase the concentration of these medications. So you want to avoid with medications like St. John's wort and grapefruit products. ADRs include hypertension, hyperglycemia, nephrotoxicity, neurotoxicity, an increase in potassium and decrease in magnesium, and QT prolongation. Black box warning include it could cause any infections, renal impairment. It's very important to monitor trough levels, monitor the patient's electrolytes, renal function, blood pressure, and blood glucose when taking these medications. With tacrolimus, you never want to start or stop any other medications when taking it. And for cyclosporine, you also don't want to start or stop any other medications abruptly. Uh, you don't want to switch any brands abruptly without contacting the provider. Do not give the medication in a plastic or styrofoam cup, and causes blood pressure, kidney issues, and gingival hyperplasia. There is a drug interaction with any CYP3A4s or P-glycoprotein medications. Moving on to everolimus and sirolimus. These are mTOR inhibitors. You want to be cautioned if the patient has an infection, not to give it if the patient has an infection. These could lead to poor wound healing and hyperlipidemia. And they are CYP3A4 substrates, so be aware when giving with medications that are inducers or inhibitors. And lastly, we have belatacept, which is a CD80 and CD86. Common ADRs include nausea, vomiting, and diarrhea. And for treatment, you want to treat latent tuberculosis infections before use. It's very important to make sure the patient does not have any tuberculosis before giving this medication. And that's all we have for transplant medications. Hope you enjoyed the video. Please make sure to like and subscribe for more, and I'll see you in the next video.